Hello, 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 YouTube world. It's Miss Patty with For Your CNA, and I'm here on our weekly live question and answer session where every Thursday at 3 we come on and answer your questions about CNA training, testing, and workplace. We're here to support you. As usual, I give a little mini lesson before we get started while you guys come in. So when you join us, just in the chat box, give me a hello. Let me know that you're here, a wave. That way we can welcome you. So today I want to talk to you. The lesson I'm going to give you actually came from one of our uh, patrons, one of our frequent joiners, Helen. She had asked this, I believe, a couple weeks ago, and I just haven't gotten to it. But her question was on the care of cognitively impaired patients. So, how do we care for patients that maybe have a limited level of understanding or unable to communicate well? And this could, I mean, this is a wide range of um, topics. Okay. So, it's kind of hard to break down. I'm going to do the best I can by segmenting this out. Okay. So the first one that comes to mind, the one that everybody thinks about immediately, is dementia. Now, dementia, for those of you that don't know, dementia is a very general term. It's called an umbrella term. It doesn't really mean anything other than the brain is sick. There's something wrong with the brain. The brain is not functioning normally. So if you got up tomorrow morning and you weren't feeling well and you went out and told your family, I feel sick, well, that tells us that you're not feeling well, but that doesn't really tell us a whole lot of anything. It just means you're not well. But what does sick really mean? Does sick mean you have a headache? Does it mean you've got a stuffy head and a cough? Does it mean you've got nausea or vomiting? Does it mean you can't get out of the bathroom? Does it mean that your urine is burning? Does it mean that your bones are aching? What does sick even mean? Right? It's a very generic term that just means not well. Well, dementia is a very generic term that means brain not well. So when we talk about dementia, it just means that there's something going on with the patient where their brain is not functioning correctly. Okay. And anytime your brain isn't functioning correctly, of course, that can affect your communication because communication is all about the brain. So when we talk about dementia, it's just kind of a generic term. We need to get a little bit more specific in a lot of cases to figure out why the brain is sick. So that's when we get into different diagnoses, like Alzheimer's. That's a specific disease that causes dementia, but so is Parkinson's or Jacobson Crutchfield disease or Lewy body dementia or multi-infarct, which is a lot of small strokes in the brain that clog up the arteries. And that means the brain isn't getting good blood flow and areas of the brain aren't functioning well. So dementia doesn't really tell us anything other than we're going to have problems communicating. Each disease is going to give us a different communication problem to overcome. So in this lesson, I want to kind of focus not on dementia, but on a specific type of dementia, Alzheimer's, because that's probably what you're asking. That's the most common type of dementia, and it gives us the most severe communication problems along the way. Now, I'll talk about some others in just a minute, but we're going to kind of focus in on this very narrow segment. Okay, so Alzheimer's disease. Now, to further complicate the issue, right? Because nothing in medicine is easy. So, to further complicate the issue, you have different levels of effect of the disease. So, if you develop Alzheimer's, you don't all of a sudden go from normal to comatose. It doesn't work that way. Alzheimer's is a very long term progressive disease where you start out getting confused, not knowing where you are, who is around you, why you're there, what you're supposed to do. So it's just kind of a general level of confusion. And then it progresses to where it impacts your ADLs. So you don't know how to use your silverware, or you don't know when you go into the bathroom that you have to take your clothes off to go to the bathroom, or you know you have to brush your teeth, but you don't know how to do it. So you lose um, different associations. That Alzheimer's is an association disease. Okay, so you may remember what um, toothbrushing is, and that you have to do it, but you don't really know how to get it done. You've totally lost toothpaste, toothbrush, sink. You've lost all of that. So it goes from confusion to impacting your ADLs to a more severe, once you get into the more severe progression, you start to lose like your willingness to do things. So you're confused at first, and then you now don't know how to eat. And then as you progress, it's like eating doesn't even, you don't recognize hunger anymore. You don't eat, you don't want to eat. It's not even really in your realm anymore. Now that doesn't happen to all time. Remember, everybody's an individual. I'm just kind of being very general here and showing you the progression. And then you get to a point where with Alzheimer's, because it's progressive, you basically lose all function and you're unable to do anything on your own in your total care. And for lack of a better term, it's almost a comatose like state. Okay, you may have some level of awareness or some level of ability, but nothing is intentional and nothing is really functional. So this is your really, really, really big arc of Alzheimer's. Okay, so starts with confusion, it moves to impacting your ADLs, your normal daily activities, to losing awareness of those daily activities, to pretty much a comatose like state. Okay, so this big arch. So let's talk about communication. So each one of these stages is going to require a little bit different communication technique, because your communication is going to be affected at all of them differently. So at the first stage, when we have that confusion, right? So communication may or may not be affected here. The patient may still be able to hear you, understand the words that you're saying, form a response, and talk adequately. So communication may or not be affected at this stage, right? So this confusion stage. So you may ask a patient, Martha, you appear confused. Do you know where you are? And she may say, no, I don't know where I am. What am I doing here? Where do I need to go? And you communicated, she listened, she understood, and she responded appropriately. Now, in the confusion stage, you may have communication difficulties. So that's a good scenario where you can still communicate, but you may have somebody that when you ask them, Martha, are you confused? You look confused. Um, she may say, apple, apple, apple. And now you have no idea what apple means, right? Maybe she wants to go apple picking. Maybe she wants an apple pie. Maybe apple has nothing to do with anything. It's just the one word her brain got stuck on today. So you can have some communication difficulties. You may have no communication difficulties, but usually in the early stage, you have something to work with. Okay. It may not be appropriate communication, but you have something to work with. Now, once we get to the next stage of this, where we end up with impairment of ADLs, communication is usually affected by this point. So when we end up with somebody that maybe knows they have to brush their teeth, but they don't remember how to brush their teeth, or they may it's a general routine. They do something every day, but they can't remember what it is they're supposed to be doing now. Um, you usually have some communication difficulties here, because if they don't remember toothbrush, toothpaste, and sink, and you say, Martha, go to the sink, get your toothbrush, wet it, and put some toothpaste on it. If they don't know those words, if those words are completely gone from them right now, and that's a problem with Alzheimer's, things come and go. It's not like a straight line. It's, you may not have toothbrush today, you got it tomorrow though. So if you're trying to give them that information and they have no idea what those words mean, what you are saying makes no sense to them. And that can cause them to be fearful, anxious, frustrated, and angry. So sometimes in this stage, you're going to get patients that kind of respond in a way that you weren't expecting. You may say, okay, Martha, go to the sink, get your toothbrush, wet it, put some toothpaste on it. And she picks something up and throws it across the room. And you're like, what just happened there? And it may be that she's reacting to the fact that her brain does not understand what you are saying. And that makes her very, very frustrated and anxious. Can you imagine for a second? You're in you're at home, right? A familiar place somewhere that you know like the back of your hand. It's you expect people there. You expect to be able to understand the people that are there, and all of a sudden, everybody around you, for no reason at all, starts speaking Swahili. You have no idea what they're saying. It makes no sense to you. And you know, you don't expect that. I mean, can you imagine how scared you would become all of a sudden if you couldn't communicate with the people around you and you could not understand what they are saying? It would be very, very frightening. So we need to understand that when we're communicating with patients with cognitive impairments, specifically brain difficulty communicating, because the lack of communication to them may be overwhelming, and it just may be just more than they can handle, and that can cause them to act out. So we need to be patient. We need to be able to repeat ourselves. We need to maybe be able to phrase it a different way, maybe use some different words that they might still have. So we really kind of have to work a little harder at this. We can't expect our patients to work any harder. Remember, they have the broken brain. So trying to put this back on them is not going to do you any good. You are going to have to adjust your communication to the needs of the patient. And one of the things that I have found with communicating with cognitively impaired individuals is that you have to slow down. So that example I gave you a minute ago with Martha. Martha, go to the sink, turn the water on, get your toothbrush, wet your toothbrush, and put some toothpaste on it. Now that's something that you could tell a 7-year-old to do, and they would do. That's something you do every day. It's a no-brainer for you, right? I love that term, no-brainer. When it comes to Alzheimer's and dementia, there's no such thing as a no-brainer because everything goes through the brain. We have to remember that. We lose routines. So you may not have to think about brushing your teeth because it's a routine, but as Alzheimer's and other dementia progresses, they've lost that routine. It is no longer a no-brainer to them. It's taking brain power that they simply don't have. So instead of giving all of those instructions all at one time, I would take Martha and walk her to the sink and say, okay, Martha, let's go to the sink. I would turn the water on. Okay, Martha, we're going to turn the water on now. And what I'm trying to do is, I don't know what words she still has in there, but I'm hoping that by showing and telling, we can maybe get that communication spark in there so she can kind of follow along. Okay, we're going to take the toothbrush and wet it. Now let's put some toothpaste on it. So I'm going to give her instructions one step at a time. And I'm most likely going to be modeling what I want her to do, as well as, or instead of just telling her to do it. Okay. I hope that kind of makes sense to you guys. So you don't overwhelm them with information. Make sure that you, if it's not, if you don't see that spark of recognition, that you take that extra step and show and tell, not just tell. Now, so that's the first two stages, right? And remember, we can get some frustration and anger at these stages. Now, let's go out a little bit longer, a little bit further in the disease process when we have um, serious impacts. So the patient doesn't even recognize hunger anymore, has no interest in eating, isn't really engaging. Now, communication is really going to be challenging at this point because in most cases, you've lost associations. So words are no longer associated with actions, thoughts, or feelings. They just they're totally separate. So I want you to imagine for a second you feel upset, unsettled, something is going on inside of you. You can't quite put your finger on it. But not only can you not tell somebody about it, like we're social creatures. Like when I am achy and I hurt and I just don't feel quite right, I complain to my husband because it makes me feel better for somebody else to know what's going on with me, right? He can't solve my problem and it probably upsets him because he can't fix me, right? But we are social creatures. We tend to share our feelings and our thoughts and what's going on with us to form a connection, but it also kind of makes us feel better to share. Okay. Now, imagine for a second you've got these feelings, these something's going on, you just don't really know, it's something's in there. But not only can you not share that with anybody else, you no longer lack the ability to interpret it yourself. So now you've got the something going on that you know something's going on, but you don't know what that something is. You can't like form any associations. You can't relay it to other people. So it's just this perpetual feeling of unsettledness, right? This anxiety, it's like a lot of noise going on, and you don't have words, you don't have feelings, you don't have any way of interpreting or relaying that noise. Now try to get something in to that. It's going to be very, very difficult. And even if something does penetrate in, they may not have the ability to understand that thing. So your patients with advanced dementia are often very anxious, have a lot of anxiety. Sometimes it will be fidgeting. Sometimes it'll manifest itself as pacing. Sometimes you'll have a patient that goes into other rooms and just takes stuff that doesn't belong to them. Sometimes you'll have just these really weird behaviors that don't really make sense to you. Well, it's because they don't have any associations and they have this communication problem. But it's not just communicating with you that's a problem. It's communicating with themselves that's a problem. So in this stage, we've got to, number one, make sure that the patient is safe because they no longer have any safety awareness at all. So safety is going to be our number one priority here. But being careful not to agitate them further. And you'll see this a lot. Patients in this stage, no is their favorite word. No, 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 no. They don't have control over anything. Not their own body, not their own thoughts, not their own feelings. They can't interpret anything. They have no idea where they are, what's happening, who you are, why they're there. They don't understand anything that's going on. It is total noise. So the only way to exert any control at all in this type of situation is no. That is the only control they have. And it's important to understand that they're not trying to be mean. They're not trying to give you a hard time. This has nothing to do with you. If you catch yourself thinking as a CNA, they're giving me a hard time, you have made it about you. And this is not about you. It has never been about you. It will never be about you. In healthcare, it's always about the patient. So you've got to rearrange your thinking here. This has nothing to do with you. The patient is experiencing a lot of noise, a lot of anxiety, a lot of inability to communicate with themselves and others. So that means that we need to work on our communication and step it up a little bit. Now, in this stage, a lot of times 1 or 2 words is preferable to a whole sentence. Like I wouldn't say, Miss Martha, would you like a peanut butter and jelly sandwich or would you like a bologna sandwich? She has no idea what I just said. No clue. What I might do instead is hold up a small triangle of a peanut butter and jelly sandwich, because small. Remember, with advanced dementia, everything needs to be small because big is too big, too big. They don't know what to do with it, too big. So small, bring everything back in. Okay. So I might hold out a piece of a peanut butter and jelly sandwich to Martha, help her take it and bring it to her mouth. This feeding. Okay. Remember, we're going to show and tell in the early stages, and we're going to bring that into the later stages as well. I hope this is making sense to you, but you want to tailor your communication to the needs of the patient, not you. Now, a couple of years ago, I heard about a situation in my local area, and it broke my heart because these are people that just truly didn't understand dementia here. So what happened was there were 2 resident aides that were working in an assisted living facility, and the nurse was noticing that the weight, or the executive administrator was noticing that the weight of the patients in there was dropping. And so started investigating, and what actually happened is that these 2 individuals were withholding food from dementia patients to teach them manners, how to say please and thank you. If the dementia patient didn't say please, they wouldn't get their food. If they didn't say thank you, there was a repercussion. And this totally misses the mark, guys. It is not, first of all, you never treat an adult like a child. That is never, ever, 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 ever in any galaxy acceptable, ever. But number 2, you've totally misunderstood what dementia is. You can't correct dementia by teaching manners. It doesn't work like that. That's like me saying I can heal a broken leg by playing cards. I mean, the 2 have nothing to do with one another. Nothing. So I don't understand that mindset there. But the other thing is that, remember, our job is to keep the patient safe and healthy. Withholding food does neither of those things. So I'm not real sure where their mindset was with this. They definitely needed some more training. This is not acceptable at all. But it also shows me a serious lack of understanding of the cognitive um, limitations of your patients with dementia. Remember that they don't understand themselves. How in the world do you expect them to understand you? So we've got to bring it in a little bit and not think so big. Keep our communication short. Try to model behavior. So take them to the sink, turn the water on. Try to find out, there's different ways of communicating with different people. Some people, verbal is still going to be okay. Other people, you're going to have to find a different way of communicating with them, maybe by holding up a sandwich or applesauce, and maybe more visual communication. You want to try to limit choices in this setting, because choices can be overwhelming. Guys, I go into the store, choices are sometimes overwhelming for me. I got to look at absolutely everything before I can make a decision, right? Choices can be very overwhelming for me, and I don't have dementia. Can you imagine having all this noise in your head and not having those connections firing the way they should, and then having a choice there? It would be, it could get very overwhelming. So limiting choices is sometimes a good option, but it's not the right one for everybody, right? So we have to tailor our communication to the patient's needs. And this is where it's going to become critical for the caregiver to really look at their own communication styles and attempts. and adjust as needed. I hope that kind of helps. So, the answer to how do you communicate with a cognitively impaired individual? The answer is, well, it depends. What is their level of ability? Because you're going to tailor your communication attempts to them. Now, I want to go on real quick to the very last stage of dementia, where your patient is pretty much comatose. They're not interacting with you, with others. They're not there's really not much awareness there, and they're, for all intents and purposes, almost comatose. Okay, a lot of caregivers will think, well, I don't have to talk to them anymore because they have advanced dementia. They don't understand what I'm saying anyway. They're comatose, whatever. I don't have to talk to them. And that's actually not the right approach. Even if somebody can't hear me, I'm still going to talk to them. Even if they don't understand me, I'm still going to talk to them. I'm going to try to maintain some level of communication, regardless of their abilities. I would never touch a comatose patient without letting them know I'm there first. I would say something like, "Hi, Miss Martha, it's Patty. I'm your CNA today. I'm going to touch your hand for a moment. How are you feeling? I hope you're feeling okay today. I know that you can't communicate, but I want to be here and let you know that I care. Okay, I'm going to be bathing you now. So let's take your gown off. And I'm going to maintain that nice, soft, smooth, easy voice. I'm going to slow my speech down, unhurried. I'm going to remain calm and soothing. And that type of approach does usually relax patients, even if they're not aware of the words that I'm using. And it can make your patients a lot more cooperative. I hope that helps you guys. Now, communication with other people that have cognitive impairments, like developmentally delayed or other types of dementia, or even those that maybe have a closed head injury or something like that. Again, you're going to tailor your communication to the needs of the patient. What do they understand? What do they show agitation with? What do you need to do, about choices? If you give them too many choices, do they look like they get overwhelmed? If you limit their choices, do they feel like you're treating them like a child? So you really want to kind of watch their reactions during your communication attempts. And then tailor it from there. So the answer is, how to communicate with cognitively impaired individuals. Well, you communicate with them at their level, not at yours. I hope that helps you guys understand a little bit more about that. Let's see who's here. Hi, Judith. Hi, Natasha. Tran, hi. And Tran asked, how often do you host this live training? Oh, Tran, I'm here every Thursday at 3 p.m. Eastern time. So same time as today, same day. So from 3 till about 3:45, I'm here doing live trainings. Tanya says, hi, Nurse Patty. I love your videos. They're so informative. I wanted to let you know that I passed my CNA written exam. Oh, congratulations, Tanya. Super excited for you. That's wonderful. Ada Obi says hi. Vanessa says hi. And Rapaluchakbu, Moses, we're going to call you Moses. Hi, Moses. Vanessa says, share the video, please, guys. Oh, thank you so much, Vanessa. I really appreciate that. Amber says, yeah, if you guys could give me a thumbs up and share the video, that would be awesome. Amber says, hi. I never asked for those things. I got to get better at that. Amber says, hi, Miss Patty. Love your videos. Currently taking the CNA class, and your videos are a ton of help for our class. Oh, awesome, Amber. I'm so glad that you joined. I'm glad you're finding my videos helpful. Blue, hey, Blue. Gregory said, Blue has given me a ton of research to go through. So thank you, Blue. You are awesome. Gregory says, thank you for all you do. Kiddist says, hi, Miss Patty. Hi, Kiddist. Gregory says, this makes sense. Oh, I'm glad you found this helpful, Gregory. Gloria, hi. Blue says, with dementia, I think I missed something here. If she's convinced her granddaughter's doll she left at her place's 2-year-old daughter, who's now 60, and it's 1965, it's okay, roll with it. Yeah, Blue. So let me explain this real quick. Let me say hi to everybody. I'm going to go back to that because there's something there that's kind of important. And this is how I explain it to my students. Hi, Milagro. Hi, Michelle. Hi, Sunshine. Milagro says, I still need to take my written test. I failed the first time, but passed the skills with your videos. Oh, well, congratulations on passing the skills. Go watch my animated lessons on my website, foryourcna.com, animated lessons. Go watch those. They'll help you with the written test. Blue says, good thing I wasn't the HR person at the facility with the ladies holding food. I would have taken everything I had not to involve bail money. Yeah, I know. I was really upset over that one too. Really upset. Hi, Mira from Dubai. Oh, wow. Ajee says, hi. Monique, hi. Happy Thursday, Monique. Let's see here. Okay, Sunshine, I'm going to get to you in just a second, but let me go back real quick. Let's talk about this. So this is something else with dementia that most people don't realize, okay? Particularly the type of dementia that's progressive, okay? So if you invented something, let's say that I invented this thingamajig, right? We're just going to call it a thingamajig, and I want to have it produced to sell. So I'm going to go find a factory to make this in, right? And I go tour 2 factories. I go tour a factory that's brand new, state-of-the-art, computerized. Everything is efficient. It runs super well. It never breaks down, and it produces really good quality pens. And then I go tour a facility that's 80 years old, broken down, rusted. The gears are like half of them are missing. Some springs aren't there. It works sometimes, but the pens that it makes may not be the highest quality and it's inconsistent. So which factory would I want to hire to make my pens if I wanted them to be good quality and consistent? I would want the new factory because it's consistent and it's good quality. Well, I want you to remember that your brain is a memory making factory. That's what your brain does. It's a factory that makes memories. Now, when your factory is new, it's state of the art. Everything works really well so that the memories that the brain makes when it's new are going to be high quality memories. Man, they're going to stick around forever because they're good quality, because the brain that made them were still very healthy, right? Now, that 80-year-old factory, the memories it makes aren't so good. And there's some days it doesn't make any memories at all because it's an older factory. It's just not functioning optimally any longer. So we have to remember that the memories that that 80-year-old factory made when it was young, those memories are going to stick around for quite some time. And this is why your patient can remember the shoes they wore to piano recital when they were 12, but they have no idea what they had for lunch because the factory that made that lunch memory isn't working today. It's offline. It's an old factory. It doesn't work every day, and that's okay. Factories age. It's okay. It doesn't make it a bad factory. It just means that what it produces isn't going to be high quality. So this is why with dementia, especially, you can have a dementia patient that looks at their granddaughter and thinks it's their daughter. Because if that's the only memory that's sticking right now, a good memory, good quality memory that was made when the brain was younger, right? So the good quality memories that are there, that are accessible right now, is if it's a child, it must be my daughter because that's the only memory that I'm able to access. That's the only memory that sticks, right? The granddaughter memories, those were made with the old rusty, broken down factory. Those don't stick around as long. So this is where you can have dementia patients that confuse family members for other family members, or they see you and think that you are their daughter. because if you're, a young female, you may have the same color hair. That must be because that's the only association they have left. Remember, I said that Alzheimer's is a disease that affects associations. So that's often what you'll have is somebody that has very, very vivid memories of early in their life, but no recent memories. It's because their memory making factory has been affected. I hope that helps. Different way of looking at it. So let's see here. Sunshine says, when going to sign up for the state test, is it required to have a CNA training course listed if you've signed up for the TNA program, or can you list the program when you register? All right, Sunshine, I think you're in Florida, if I remember correctly. In Florida, you're going to register as a challenger, so E3 challenger. Now, if you're in any other state, I'm not real sure how they're handling the TNA to CNA changeover. Well, let me back up. Every state's handling that a little bit differently because the TNA, so every state's allowing challengers right now as long as you're a TNA transitioning to that CNA without education. But I don't know how they're handling it on the registration form. So that's something that I would certainly go talk to your administrator about or your director of nurses, because they will know how to get their TNAs registered for the exam to get them certified as CNAs. So if you're in Florida, you're going to check Challenger. If you're in any other state transitioning, check with your DON. Okay, they'll tell you what to do. I do know that there's 2 states for sure that the DON has to write a letter authorizing you, basically to test. So check with your DON. Okay. Let's see here. Wendy says hello from New York. Hello. Natalie says, hi, Miss Pat. I don't get notifications when you go live. Okay, Natalie, if you want notifications, YouTube makes this super hard. I'm very sorry. But you have to like my channel, and then you have to ring that little bell, or I'm sorry, subscribe to my channel, and then ring that little bell. When you ring the little bell, you'll get notifications when I go live, but you have to ring the bell. I don't know why they make this so difficult. I know that I have a virtual assistant starting next week. I'm super, super excited. Her name is Mai, and she is going to save me. I'm just so excited. But anyway, one of the things that I'm going to be asking her to look into is a way for us to notify anybody that has subscribed to my website, hey, we're going live in 15 minutes. So it'll be an email that goes out with a link that you'll be able to join. So I'm hoping that she'll be able to set all that up for me. I'm not real good with tech. I'm still learning. So I'm really hoping that she'll be able to get that set up. So hopefully we'll have that moving forward. But in the meantime, on my channel, hit subscribe and then the bell, and that'll get you notified by YouTube. All right, so let's see here. Krista, hi. Wendy, tests on the 16th. Oh, how exciting. It's 2 weeks, just over 2 weeks away. Make sure you go to my website, watch my skills videos and animated lessons. There's practice tests on there too for you that you might find helpful. And if you've got any questions, come back here and let us know and we'll answer them for you. Faith says, hi. Amanda, what is the best advice you can give a CNA just starting out? Oh, that is a really good question. Okay. There's 3 pieces of advice I would give you. The first is breathe. You got past the test. Now what? Right. But you're still probably pretty keyed up and you're probably a little bit afraid because now you've got past the test. That's good. But now you've got to work with real live people, and that can be intimidating and it can be a little bit scary. So first, breathe. You're going to be okay. The second is that I would make sure, absolutely sure, that I was familiar with the policies and procedures where I'm going to work. So when you go to work somewhere, you're going to go through an orientation period. They're going to match you up with a preceptor. The preceptor is going to show you around, show you how things are done, where supplies are, all of that kind of thing. And then they're going to tell you how they do things there. And that's good. but that may not be necessarily how the boss wants things done there. So during your orientation, you really should take some time to go through the policies and procedures and look at the things you know you're going to be doing frequently, like bed baths or ambulating patients or helping them to the toilet or vital signs or whatever. But go through that policy and procedure manual and get a good sense of how the facility wants things done, and make sure that you're doing things according to that policy and procedure. Now, the care plan is going to help you adapt that task to the patient, but you first have to know how the task should be done by the facility. So you have your training, then you have policies and procedures that tell you how things should be done here, and then you have the care plan that adapts that to the patient. So there's 3 levels here. Make sure you're familiar with all of them. But a lot of people just kind of gloss over that whole policy and procedure thing. I've worked with CNAs that went, a what? We're supposed to do that? Or we're supposed to know what that is? Well, I don't even know where it's at. So it's always a good idea to take some time and learn the policies and procedures where you work. So that's number 2. So first, breathe. Second, make sure you know how you're supposed to do things where you're working. And the third thing is to work hard to become an asset to your company. Now, what I mean by that is a little bit different than what most people think. Okay. I don't want you to run around kissing somebody's butt. That's not what this is. But I do want you to make sure that you're on the right team. So it should be you and the nurse versus whatever's trying to kill the patient. So make sure you're on the right team. If you are against the nurse, if you are finding yourself at odds with the nurse, that means that you guys are not united and you're not fighting the same enemy. So the nurse may be fighting whatever's trying to kill the patient, and you're fighting the nurse. You're not on the same team. So you've got to make sure that you're aligned well with your nursing staff. You also want to be an asset to your other coworkers, the CNAs. So if somebody asks you, hey, can you help me roll this patient over? You need to try to help them, not come up with, well, I'm too busy. I've got too much to do. I don't want to be helping you, because you're going to need help at some point too. If you have to work a mechanical lift, there needs to be 2 people there, one to work the controls, one to watch the patient. If you're not helping somebody else, they're not going to help you. And all that does is put the patients at risk, because now we're working mechanical lifts alone. Now we're turning patients without somebody's help, which can cause them injury. They can fall off the bed or whatever. So make sure that you're working well with your team members. And part of that is to try to avoid cliques. There's a lot of cliques in healthcare. People work together for a while, they become very chummy, there's inside jokes, there's part of the club. But before you know it, if you've got a club going, that means that there's always outsiders. I mean, if everybody is part of the club, it's not a club, it's a work environment. If there's a club, then that means there's always outsiders that aren't allowed in. And that, again, sets up a very poor working environment. The other thing that I would say is never forget why you're there. It's always about the patient. When you start making it about you, if you're using a lot of I statements, it might be time to reevaluate, because you're not really doing the patients as much good as you could be. So try not to forget the spark that led you into healthcare. And it's hard. Guys, it's so hard. There is way more work out there than we can get done. There are more patients, there are more tasks. There's just more than we can handle. And it's really easy to get burned out and to start focusing on you. But be careful, because when you start focusing on you, you lose sight of why you're there, and that's when burnout happens. So be careful. Make sure you're communicating with your team. Hey, I'm falling apart here. I need help. I need help. And make sure that your supervisors know when you're falling apart so they can help. We're all working short-staffed. It's miserable, and I get it. I get it. But if we're all miserable and nobody's really watching out for the patients, then why are we here to begin with? So we really have to make sure that we're kind of checking ourselves as well. I hope that helps. Kakuza says, greetings from Uganda. Oh, wow. Nice. Miles says, any tips for beginner nursing assistant students in a clinical setting? Yeah, Miles, just listen 5 minutes ago. I didn't see that. Yvette says, I go take the written portion on the 6th. Oh, right around the corner. Okay, 5 things, and then we're going to wrap up here. 5 things for the written test. Know your role. Care plan, the whole care plan, nothing but the care plan, report everything to the nurse, right? The second thing is know your normals. So you remember what sets CNAs apart from others is that CNAs have the knowledge and training to know abnormal, because that's what we're reporting to the nurses. So you have to know normals to be able to learn what's abnormal. So know your normals. That's normal aging, normal vital signs, know your normals. The third thing is patient rights. Don't forget it's all about the patient. So anything on the test that treats a patient like a child is not the right answer ever. You have to understand safety and infection control. Those are the big 5 things on the written test. Every question is going to address one of those 5 things. Okay. Krista says, I'm still scared of going back to retake my written test. I'm feeling ready yet. I think it's you're not feeling ready yet. Yeah. Well, focus on those 5 things, Krista, and go watch my animated lessons. They will help you. I promise. Sunshine says you're in Pennsylvania. Yeah, Pennsylvania, I'm not real sure. I think, if I'm not mistaken, in Pennsylvania, there is a, and I haven't looked at the application in a while, so I'm not real sure, but I do believe that there is a box to check on there that is, I can't remember what it says, but it's something like I'm drawing a blank right now. I can't see the registration packet in front of me. Go talk to your DON, Sunshine. They'll know what option you have to check. But I believe there's something on there about other nursing training or other something, and that's what you're going to have to check in Pennsylvania. But again, I don't know. So go check with your DON, because they will have the most up-to-date information for your specific state. Okay. And then let us know how you do. Akpu says, I've tried the CNA test time, but I couldn't pass the test. What do I do next? So I'm thinking you've tested 3 times. You'll have to go back through a program to be eligible to test in most states. If they give you 3 attempts, if you don't pass, most of the time that requires remedial training. So you have to go through another CNA program. Michelle says, hi, Miss Patty. What is normal for blood pressure and respiration? I'm a little confused with what you were taught, and you'll be tested soon. Okay. So normal vital signs really quickly. Oh, we're running low on time. Normal vital signs: pulse 60 to 100, respirations 12 to 20, blood pressure top number or systolic 100 to 119, bottom number or diastolic 60 to 79, and temperature 98.6 a degree in either direction is considered normal. So 97.6 to 99.6 is considered normal. Okay. Miles says that was great. Thank you. And Akpui says, I've tried the test 3 times and I couldn't pass. Yeah, unfortunately, you're going to have to go back through a CNA program for remedial training to be eligible to test. And I'm so sorry that you were unsuccessful. Let me know how we can help. Go to our website, watch our skills videos and animated lessons. They'll help you. All right, guys. So we have got a whole bunch of people to congratulate. Let me just pull this up. Hold on 1 second. All right. So here we go. You ready? These are all the people that passed, and let me know this week they passed. And we've got a lot of you guys. So here we go. Travis Soleil tested on 6/28 and is getting ready to start the RN program. So congratulations and best of luck. Ms. Tasha let me know. She dropped me a line on one of my videos and said she was so nervous for the test that when she went in to test, she tried to reschedule. She's like, I can't do this. I'm too nervous. I can't do this. And she tried to reschedule and they wouldn't let her. They made her test and she passed. And the evaluator told her she did fantastic. So I know the test is scary, but have a little bit of faith in yourself. You can do this. Okay. Lena Luna Taylor passed the CNA state exam. Vera Patupe passed the CNA state exam this week. Jennifer Ocasio also passed the state exam. Erica Ornalis passed on the 24th and let us know. So almost a week ago. Ebony Diaz and the Dalpuri. I'm probably butchering that. I'm sorry. But all of those people passed the CNA state exam, and we're super proud of you. And we want to welcome you into healthcare. Now, we do have a couple that are testing soon. Kazel is testing today. So good vibes, good vibes. And Stephanie Rodarte is testing soon, but I don't know when. Stephanie didn't let us know when she was testing, but we're going to send good vibes out in her direction anyway. Sonia Henderson tested yesterday, so hopefully she'll come back and let us know how she did. And it's Vasm also tested last week, and we haven't heard. So those of you who are testing soon, make sure you come back and let us know. We're invested now. We want to know how you did. And that way we can congratulate you. And when you do pass, drop us a line on any of my videos. And that way we can congratulate you and welcome you into healthcare as well. So I'm so glad you guys all joined me today. This was a very, very fun session. And I really like talking about communication and the changes that occur with different health conditions. And we'll go over a few more as we go. Let's see here. Alexandre. Okay. So Alexandre says, can you please give me a tip on how to measure pulse and come up with a correct number? So Alexandre, I'm going to make you next week's theory lesson. So we're going to talk about pulse next week. I'm going to explain to you how to take a pulse, how to find a pulse, some tips and tricks, and we'll talk about some things that could affect heart rate as well. So next week, Alexandre, will be all about you. We'll talk all about the pulse. So make sure you tune in Thursdays at 3 and learn more about that. Sunshine says, thanks, Miss Patty, for all you do. Michelle says, thank you. And Alexandre says, I'm having trouble measuring blood pressure and pulse to come up with the exact numbers. So, yeah, we'll talk about pulse specifically next week. All right, guys, that's going to wrap up today's session. Thanks for joining. We'll be here next Thursday at 3 p.m. Eastern, so we hope that you can join us. Until next week, happy caregiving. Bye.